breaking barriers and bridging the gaps between patients and doctors. Welcome to Brainstorming with the Docs and your co-hosts, Dr. Glenn Harrison and Dr. Kolby Condos.
Welcome back, everyone. You are tuning in to another episode of Brainstorming with Dr. Glenn Harrison and Dr. Kolby Condos. We are going to continue our journey today on exploring the thyroid and what thyroid disease looks like. We're going to break down the simple physiology of the thyroid and some common lab tests and some uncommon lab tests that can be used to really check and ensure that your thyroid is functioning optimally. And if you do suffer from thyroid pathology, what it looks like, what the lab findings will be, and what are some steps that you can use to kind of help correct that naturally. And if you need some medical interventions, what those would look like also. So without further ado, I'm going to let Dr. Glenn kick it off for us.
Well, thank you, Kolby. How are you doing today?
Man, I can't complain. Been a little busy. Been enjoying this nice fall weather. What about yourself?
Well, here in Denver, it's been warm, and now we're going to get some snow, I think tomorrow or something like that. But the weather's beautiful. Everything is going great, but I'm really excited about jumping into this topic. I know you and I are working with these things all the time. So to give the pieces of it in these segments, I think is really exciting. And really today, diving into I like to call it the meat and potatoes of the thyroid, because this is where the magic happens. It's in the physiology. So first, to jump into our piece today on the physiology of the thyroid. So as we talked about in the previous segment, the thyroid is that butterfly-shaped gland in the neck, and it's the powerhouse. And the thyroid cannot do anything by itself. It needs the brain to send a signal to the thyroid. So to simplify, the brain sends a signal to the thyroid, and the thyroid only makes two hormones. One hormone is something called T3, and the other hormone is something called T4. Now, we can't use the T4. I'll put four fingers up. We can't use the T4, so we have to use the T3. And this is a problem because the majority of what the thyroid makes is in the form of T4. So we need to convert the T4 into T3, something we can use. And this conversion happens in a few places. T4 has to travel to the liver. The liver converts some of this T4 into true T3 that we can use, and then it converts some of the T4 into different types of T3 that aren't quite a true T3. So part of that T4 conversion actually goes to the gut. So to simplify back, the thyroid makes those two hormones, T4, T3. The T4 we can't use, the T3 we can. The T4 goes to the liver, and some of it converts in the liver. 60% of this T4 converts into a true T3 that we can use. And 20% of this T4 goes to the gut and gets converted. So you need the gut to work very properly, work well to be able to get 20% of your thyroid function, and your liver is responsible for about 50% of your thyroid function. The thyroid produces very little T3. So we need multiple organ systems to work to have true thyroid function. As we mentioned in the previous segment, there's over 20 million Americans dealing with thyroid disorder, and it's because of all of these weak pieces. So I'll let you take it there from there, Dr. Kolby, regarding where the problems lie. I laid out the organ systems and everything, but some of the diagnoses, I know I get a lot of people, they heard of Hashimoto's, they heard of Graves', they heard of hypothyroidism, they heard of hyperthyroidism, and then all these names get mixed up and they get confused. Could you kind of elaborate on that?
Yeah, absolutely. So I think that you laid out the physiology beautifully, because basically when you look at the diagnoses of thyroid dysfunction, you look at basically either low or high, right? Hypo or hyper. Hypo is low, hyper is high. Hypothyroidism includes things like, weight gain, hair loss, can have heart palpitations, fatigue, hyper, warm, moist skin, rapid heartbeat, sweating, hair growth, that kind of stuff. But then within the hypo, there's two different kind of classifications, which is Hashimoto's, which is an autoimmune condition where you actually have antibodies. Your immune system has made antibodies to either your thyroid or enzymes in your thyroid or a protein that helps you move thyroid hormone around. So Hashimoto's would be the presence of what's called a thyroid paradoxase antibody to a thyrobinding globulin antibody. or it can be to actually the enzymes that break T4 down into T3. Graves' disease would be where you have excess production of the thyroid hormone T4 and T3. And that would be if you had something like a thyroid tumor, a thyroid hormone producing tumor, or if you had like a tumor in your anterior pituitary gland, an anterior or a pituitary adenoma, which can actually cause like increased amounts of thyroid hormone production also. So that's where it really, that's where you need to seek the help of a qualified medical professional, because even though the thyroid is very important and, these symptoms, everyone thinks that they're suffering from them. If you're suffering from something like Graves' disease, that needs to be medically managed. Hypothyroidism can be managed, with the use of, exogenous thyroid hormone like Synthroid or Armour, but it can also, there's things that you can do naturally to help increase the production of thyroid hormone also. So
Okay, so just to summarize, you talked about something called hypo, low thyroid, hyper, high thyroid, and then some of these common conditions, because it can be broken down. Someone can have low thyroid for lots of reasons, right? Like the liver not converting T3, so to T3, so thyroid hormone's low, or the gut not converting. So overall, your T3 and T4 levels low. But then another layer of this, so you could have, the individual could just have low thyroid, but then the cause of the thyroid could be these organ system dysfunctions, or you mentioned something called Hashimoto's. So Hashimoto's is just an autoimmune condition where the immune system attacks oneself, and it usually leads to low thyroid function. Would that be right to say, Dr. Kolby?
yeah, yep, absolutely. That's a good way of summarizing it. There's a variety of reasons why you can have an underperforming thyroid, and that's where the laboratory workup really comes in as a really invaluable tool, so that you can determine, is it truly a low underperforming thyroid? Is it an issue with conversion? Are you truly making the normal amounts of T4, but it's just not being degraded into T3? Or do you have antibodies to the enzymes that's helping you make thyroid hormone to begin with?
Okay, so antibodies, for our viewers, it just means your body is making immune soldiers that are damaging your thyroid tissue, and there's two different major forms of autoimmune disease for thyroid is Hashimoto's, which a lot of times can lead to low thyroid function, or Graves' disease, which can lead to high thyroid function, too high. So with the thyroid, we never want too much or too little because it's so important. So I know you touched on lab testing. Now, everybody comes into my office with this ridiculous one lab test, and then I have to talk about them, all of the other lab tests that would be better. What do you recommend when it comes to thyroid lab tests to know the whole picture?
Yeah, so most practitioners run a TSH and T4 because those are inversely proportional, which means if the T4 is high, the TSH will be low. If the TSH is high, and then the T4 is low. So if one is high, the other is low. If the other's, kind of vice versa. And that's valuable, but it's not a good snapshot of the complete picture. So when you want to look at the complete picture, you want to look at, how is the precursor, the TSH, is there an issue with the precursor to the precursor, which would come from the hypothalamus, which is a part in the top of your brain. You want to look at, is there an issue with T4? Is there an issue with T3? If there is, why? Is it because they're thyroid paradoxase, which is an enzyme that packages all these little iodine molecules together in the thyroid? Is there an antibody or a little soldier that's beating those things up so it's not working as well as it should? If you're making the right amounts of the hormone, is it able to catch, a taxi to the end organ or to the liver and the gut? Is there little soldiers attacking the cars? So that's the important part. You want to run a full comprehensive thyroid workup, because not only if you have a thyroid condition will it help you find it, but then it can also help you develop better strategies for the management of it.
Okay. So do you, I might be putting you on the spot, do you remember off the top of your head of which lab markers are involved in the thyroid panel?
Okay, so there's TSH, which is thyroxine, and then there's T4 and T3. There's TPO antibodies. There's TBG antibodies. There's reverse T3, free T3, T4, T3. Did I mention that one already? I can't remember.
You mentioned the freeze and the non-freeze. Yeah.
Reverse. T3 active, T3 uptake.
Yeah,
So
I think you got all of them. What we'll do in the notes, we'll put in a link. I'll have a video where I draw all the thyroid physiology out, and then we can introduce all those lab markers. There'll even be a link in there where you can actually order these lab markers. So, you know, that we'll have all of this. I know we're rattling off a lot of information. If people have a visual, it'll be much easier. Now, that's kind of in the lab world of, you know, the blood lab of understanding the thyroid and finding the strategies to where the weak link is. Because I talked about thyroid function starting in the brain. The brain sends a hormone called TSH stimulating the thyroid, and the thyroid makes the T3 and T4. So there can be a weak link anywhere along the chain, and as you said, Dr. Kolby, if you know where the weak link is in the chain, well, then that's the place you can focus on, whether it's antibodies, Hashimoto's, whether it's the liver not converting, whether it's the gut not converting, or what have you. So that's the blood, and that's the physiology of the blood. But what about other strategies? I know you've seen some crazy antibodies, and I know you talked about ultrasound and stuff like that. What, even palpation, you know, maybe throw a case out there if you have. I know you probably do. Of you did, because you told me about that one you palpated and you found a nodule. Explain different strategies for diagnosis.
yeah, so obviously the lab work is really, really important, and there's no substitute for the lab work. But that being said, because I do a lot of neurological exams, when I am actually performing my neurological exam, I'll actually palpate and feel the thyroid, and then I'll use tangential lighting to look at the thyroid. And basically that's just lighting from a different angle so you can see, you know, the different lobes of the thyroid. And when I was looking at this patient, I'm like, wow, it really looks like, you know, the right side of their throat is swollen. You know, I asked the patient, you have difficulty swallowing? Yes, I do. I have really, you know, it's difficult to swallow. My voice has gotten super hoarse. It's really weird. I feel like I'm always like not really gagging, but I'm choking on food. So after I did the exam, I was like, wow, you know, this patient might have a lot of swelling on their thyroid. And it could be thyroiditis, it could be Hashimoto's, whatever. So I ordered the blood test and I ordered the full thyroid panel. When the thyroid panel came back, her TBG antibodies were at like 2,100. And that's really high.
You remember what normal is? I think it's less than 3.
Yeah,
Oh,
I think it is.
wow.
And
I never know.
Yeah, 2,100. I saw it and I was like, oh, wow, this is bad. So when that comes out, that's kind of an ominous sign, which means it's really bad, right? So I sent her out to an endocrinologist, and I was like, hey, I think that this patient might have thyroid cancer. I think that she needs an ultrasound. They did an ultrasound on the patient. The endocrinologist called me. He's like, hey, you know, I appreciate the really thorough workup. You were right. There is a nodule on the right side of her thyroid. We did an ultrasound, you know, and it looks like it could be cancerous. We're going to do a needle biopsy where they went in there and they actually took a chunk of the nodule out. It was cancerous and they removed it. And actually they said that if it were to continue, it would have actually caused her to have impaired ability to speak, phonation.
Wow.
So yeah, I mean, this is some stuff where you don't think that you'll normally see it in your day-to-day life, but I mean, it can walk in and it does.
Yeah. Yeah. So I guess, like you said, there's no replacement for blood work, because that's the first step, right? First step is a screening to know where all the weak links are. Is there any weak links? Is your symptoms, whether it's weight gain or hair thinning or infertility or joint pain, any of that, dry skin, is it due to a thyroid problem? And the majority of thyroid problems, you know, they're hypothyroid, low thyroid, but there are some of those hyperthyroid where the body is sped up and everything is moving fast. But, you know, some of the questions I get, Dr. Kolby, one question I get when I'm presenting or something on the thyroid, people will come up to me and ask, you know, is there anything that can be done with someone without a thyroid?
Yeah, I mean, so can you phrase that again? Is there anything that can be done for people who don't have a thyroid?
Yeah, who don't have a thyroid, like in the situation that you just talked about, that case.
Yeah, sure. Here's the important thing to really understand with the thyroid is, say that you have had your thyroid removed. You can still have Hashimoto's if there's one single cell left. You can still make antibodies to a single cell. So you can still have consequences of Hashimoto's, autoimmune thyroiditis, even if you think your thyroid is completely gone. And the thing is if you look at, the thyroid replacement hormone therapy, if they're not able to convert, or if they're not able to actually move that thyroid around in their body to the places where they need it to go, then it's kind of useless. Not useless, but maybe not as productive as it could have been.
So yeah, back to the physiology. I talked about the liver and the gut. If you're taking T4, most thyroid hormone is in the form of T4 and medication. So if you can't convert that T4, you can't get any use out of T4. So if someone has their thyroid removed and they're on the medication, there are, like what you're saying, there still are strategies in the aid of helping that T4 convert. So you can get the benefits of your medication even without a thyroid, but you do need that. You do need that medication. But working on liver health and gut health and so many more. Another question is, what do you see? I know I see some cases in my office about iodine. Have it, don't have it. I know that's going to be a question, so I'll let you answer that one, or give me your take on it.
Yeah, so, I mean, everyone's kind of got their own opinion. Mine is that America, because most of our patients are going to live in the United States, in the United States, we are an iodine replete area, which means we have a huge amount of availability of iodine. So I am not a fan of my patients taking iodine supplementation unless we know 100% that they need it. If you were in a place like Greenland or somewhere where it's an iodine deplete area, then maybe that would be a good therapy. But as far as like most of our patients who are in the United States, I'm not a huge fan of the iodine supplementation. I know that there has been instances where actually supplementing iodine for people who have thyroid disorders or disease can actually provoke an autoimmune condition. Have you heard that too?
Yeah, I've seen that. I've seen some research on that. I've seen a lot of research on people who have Hashimoto's, specifically Hashimoto's. They take iodine, it will make it worse. I've seen that. I also have heard reports of people saying that iodine made them feel better, even though they had Hashimoto's. But usually I'm pretty quick to identify if they have Hashimoto's or not. And as you said, I never hardly ever see iodine depleted enough in anybody for it to be the cause of the problem, because it's everywhere. We can't avoid iodine.
Right. So I know that we've been talking about that patient that you had that had the depression, right? And that they had an underlying autoimmune condition to their thyroid. Why don't you extrapolate a little bit on that and give people an idea about maybe some of the cofactors that kind of roll in all together with the thyroid, and break that down a little bit.
Kind of like associated conditions. Yeah. So Hashimoto's thyroid, that makes up something like, I think 90% of thyroid disorders, is autoimmunity, where your immune system decides it wants to attack your thyroid. And if you have one autoimmune condition, there's a 50 to 60% chance you're going to have another one. And then that can be many other autoimmune conditions. It could be things like rheumatoid arthritis, celiac disease, Crohn's, ulcerative colitis, polycystic ovarian syndrome, endometriosis, multiple sclerosis. There's just so many of these autoimmune conditions. So, there was this case that I saw. She, actually, there was a brand new one. I guess I might as well talk about a new one. It seems like every other day there's a Hashimoto's case walking in, and she found out she actually did have the antibody. She knew, and it's not very common where we're getting people coming in that know they have Hashimoto's, meaning they have the antibodies and it's been identified in their labs. Because in all reality, there's 12 markers. I think we talked about this in the past, and in our conventional medical model, we'll only test 2, really 1 or 2, maybe 3, but not 12. You got to do all of them, and they'll be in the description. But anyway, she came in and she had Hashimoto's. So we were on the hunt for other conditions, and what did we find? We identified she had all this digestive issues. So we sent her to her medical doctor, and they did a scope, and they found celiac disease. And then that wasn't enough. We started working, and she really started to talk about how her hands were inflamed and swollen and painful in the morning, her grip strength and everything. And now we're looking at rheumatoid arthritis. So if you have one autoimmune condition, severe thyroid, rule in or out autoimmunity. And And if it is autoimmune, do the test. If it is autoimmune, do not ignore other conditions of autoimmunity. But really, these symptoms of being lethargic and tired are just some of the symptoms. Sometimes because this immune system is or the thyroid is such a drill sergeant, I talked about in the last podcast, it determines your immune status. Are you going to have a strong immune system or a weak immune system? It determines your muscle building and your fat burning. It determines even your mindset. Maybe that's why you mentioned depression. But if people are tired, well, naturally they're not going to be motivated and they're going to be depressed. But if people are dealing with a thyroid issue, there's a lot of brain inflammation. And I know this is where you could chime in, Dr. Kolby, what you see with Hashimoto's and brain inflammation.
Yeah, I mean, inflammation on the brain is huge. Just systemic inflammation is anytime you have that, then you're going to really have some negative consequences of that. There's certain parts of your brain that are more susceptible to inflammation than others. And that's where you can get things like, memory loss or, alterations in your perception, or, these are the people that, I forgot where my keys are. Oh man, where'd I put my glasses? Hey honey, have you seen my wallet? That type of stuff. All that stuff can be tied really back to the thyroid. You could go on and on about it, about how that, that inflammation can set you up for negative consequences down the line, such as the possibility of dementia, development of MS, predisposition to, negative consequences associated with head trauma or brain injuries. All that stuff really ties together. And that's why it's so important to understand the physiology and know going into it, because a lot of these conditions can actually have really, really strong long-term consequences if they go undiagnosed and untreated.
Yeah, for sure. And everything is connected. So if there's a problem with the thyroid, I know you and I both learned that the thyroid is the second most important thing on a lab panel. And if it's not working, all sorts of other symptoms can come to surface. So I guess for all the viewers, if you are concerned about thyroid, have any of the symptoms that we talked about in the past, by all means, order the panel, get it done, find out where the problems lie. Maybe there are no problems. I've had people that have been diagnosed with thyroid disorders, and they came into my office and we ran a true panel. They found out it wasn't a thyroid problem at all. I've had people where their thyroid was dismissed and said everything is good. I know you have, Dr. Kolby, as well. And then we find out, oh my goodness, this thyroid is actually severe. So never underestimate the power of blood work to get the answers that you need and kind of avoid all of this. And the sooner you find the answers, for example, if it is Hashimoto's, your immune system is damaging your thyroid, you want to identify not only if you have Hashimoto's, but so you can do something about it and start working with your immune system so your immune system backs off from your thyroid and you can start preserving it. So I guess if you're dealing with symptoms, don't wait. Right.
You only have a finite number of thyroid cells. When they're gone, they're gone. If your immune system destroys all of them, you're kind of SOL. Then you're on, hormone replacement. So like Dr. Glenn said, don't wait. Don't dismiss it. If you're having, these symptoms that we outlined, not only in this podcast, but the one previous. If you missed the one previous, go back and watch it. Don't wait.
Yeah.
I don't know how else to say or press upon you that it's important to take care of it now. So just take care of it now, right?
Yeah, for sure. So I think that's all I had to cover. Did you have anything else this session?
No, I think that we did a pretty good job in summarizing, some of the conditions and what some of the workup looks like on it. So on the next one, we are going to break down some common strategies or not necessarily treatment, but management of thyroid conditions. So if you thought that this one is useful or interesting, please tune into the next session of brainstorming with Dr. Harrison and Dr. Condos. And without further, until next time, buddy, I'll talk to you later.
Okay. You have a great night.